easily torn. Okay? Well, I have that way too close. I'd forgotten to turn it on. So it bleeds easily when it's friable. That cervix, and it looks like velvet. It kind of has a soft, not shiny appearance, but more velvety. And so it damages really easily and bleeds easily. So that is an important point because sometimes moms will have a little vaginal bleeding because of the friable cervix. Okay, so friability, and it's all because of the vascularity. Okay. This is what the growth looks like of the uterus. The lowest is at 12 weeks. By 12 weeks, it's coming and peaking up over, you can feel the uterus above the symphysis pubis, right? So, yeah. Okay. And then you can see by 20 weeks in the middle of the pregnancy, we're at the umbilicus. And then we grow. Okay? So this is what happens. Notice 36 is the solid line, but when lightning happens at 40 weeks, the baby moves down farther into the pelvis. Okay? Usually at about 14 weeks is when moms start to show. Okay? Like Nicole, our sim coordinator who just had a baby, she swore she was pregnant. We didn't believe her. She's very slim, but it matters that you have really good abdominal muscles, and she has a really long torso. So it took forever for her to look like she was pregnant. There are some people, like I would be, I'm imagining Janaea would be that way too. Some of us really short. I'm very short-waisted. If I had gotten pregnant, you would have known probably in the second week. Okay? There's just no room to go but out. You weren't that way? Seriously? You must have a long torso then. Not really? Oh, yeah. Yeah. Yeah, that is probably the reason for that. Yeah. And then, usually in the second pregnancy, you will see, because those abdominal muscles have been stretched so much, usually moms will show more quickly. Unless they're really great athletes. Okay. Still on reproductive. Now we're looking at breasts. Breasts become enlarged, they get bigger and more sensitive. Sensitive is the word. That's in the underlined. So they can actually be uncomfortable. You have the Montgomery tubercles are much more noticeable. They become bigger, and those are oil glands that are in the areola. So the little bumps on the areola, those are Montgomery tubercles, and they become bigger. They lubricate the areola, and it's also an anti-infective for the breast. What's colostrum, OB friends? It's the very first milk. Liquid gold would be another word for it. It's not big in volume. You don't have a lot of volume of colostrum. Okay, so it's the milk before the milk, but it is packed with antibodies that protect the baby. So colostrum is really important. Moms will start secreting colostrum in their breast by the 3rd month of pregnancy. And by 16 weeks, they can have colostrum actually leaking out of their breasts. Some moms have to wear breast pads. Colostrum is pretty miraculous in that if you had a baby at 25 weeks, your colostrum would be the perfect food for a 25-week-old baby, okay, and so on. So when a mom delivers that term, her colostrum is just right for a term baby. Kind of miraculous. Notice also that the veins in the breast become more prominent, and the areolas will get darker. So those are the changes of the breast. Also, sometimes they get so big you start to get stretch marks on your breast. Yes?
Can you repeat the part where they start secreting by the 3rd month of pregnancy?
Colostrum. Yep. So the breasts start making colostrum by the 3rd month of pregnancy, and then at 16 weeks, they can actually start leaking. Yeah, will start leaking out. Okay, what did I say that this semester is all about? In the very beginning, perfusion, okay? Besides all of the rest of this being miraculous, one of the biggest deals and one of the most important concepts that you guys need to learn or know about are the adaptations of mom's cardiovascular system to pregnancy, okay? Mom's blood volume, if you look at the bottom paragraph, mom's blood volume actually increases by nearly 50%. She's got way more volume. Way more volume. The reason why? She needs to support a whole nother person. She's got to have that extra volume because it's making a detour in through the placenta, through the baby, and coming out again, all right? Mom has to be able to perfuse that placenta. So her blood volume increases exponentially, okay? The heart, actually, because of all that volume, it will get bigger and it will actually shift position. So it'll be more centered, a little rounder, and it goes back to normal afterwards. After delivery, yeah. So having all this extra blood is a protective mechanism, all right? Again, keeps the mom and the baby hydrated because they need to be hydrated at all times. When mom delivers the baby, she will bleed, and so that extra volume, even though the baby's out, the extra volume is valuable because she's going to have a blood loss, all right? So it compensates for the blood loss, all right? It also gives mom a fluid reserve in case of illness. Dehydration, bad for pregnancy, very bad. Blood pressure actually stays the same. Usually, in the very beginning, you might have some decrease in blood pressure, especially orthostatic hypotension. One of the more important things that we worry about and that you're gonna have to remember is that if mom is lying on her back, especially as her uterus is bigger, that uterus will press on the inferior vena cava and it will compress it enough that her blood pressure will just tank, okay? All right, so you get sudden hypotension. It's positional hypotension because of uterine pressure on the inferior vena cava. If you think about that inferior vena cava is sitting between the spine and the uterus, and if she's lying flat on her back, it will smush it and give up more resistance, so mom's blood pressure, bam. Okay? So, That's something to remember. All right, so cardiac output then increases by about 750 mils per minute. It increases by about 750 mils per minute. The normal cardiac output is about 5 to 6 liters. So what do you think happens with mom's heart rate? If you have increased cardiac output, you're going to have a higher heart rate, right? It starts increasing as that volume starts increasing. So about by 5 weeks, it's about 10 to 15 beats per minute faster. And then because of all this extra blood volume, because of all this extra work that the heart is doing, by 32 weeks, you'll start to see murmurs. Okay, those valves get stressed a little bit. So you start to hear murmurs, and it's very common for moms to have palpitations. All right, that would be normal. Obviously, someone who has cardiac problems anyway, we would be watching very closely at this time. After delivery, these will, again, as in the first 2 weeks postpartum, they will resolve. 10 to 15 beats per minute faster. Okay. So that cardiac output thing, go back to it again and again, okay? Think about all that extra blood volume and what it does to mama, okay? And then circulation and coagulation times. Pregnancy is considered a hypercoagulable state. Say that fast 3 times, okay? Hypercoagulable. What does hypercoagulable mean? What? It clots more easily, all right? Now, that's not necessarily a bad thing. The clotting factors actually increase, but they do that to protect mom from bleeding to death, okay? So that is on purpose. It's a protective mechanism. We don't want mom to bleed to death with those increased clotting factors. But moms also have a 5 to 6 times increased risk of stroke, both during pregnancy and postpartum. So they have a higher chance of throwing a clot. How would we combat this to protect mom? What would be important then? If she's hypercoagulable, what don't you want to happen? Her sitting all day is a good one. Well, yeah, that goes without saying. I don't want anybody smoking, right? Getting dehydrated. You were saying that. You could have said it out loud, and you would have been right. Not that you guys weren't right, but what I'm thinking of is, so getting dehydrated is bad for moms and pregnancies. So it's very, very important to encourage moms to stay hydrated. Okay, our respiratory system, because of all this stuff, you know, moms have more pressure on their diaphragm as the pregnancy grows. There's less room for everything. Everything is smushed in her abdomen, including the lungs. There's less, she has less of an ability to take a deep breath. So we see an increase in O2 needs. And so The body compensates by this by increasing the metabolic rate, or it's because of the increased metabolic rate and fetus. But it basically puts mom into a metabolic alkalosis. Pregnancy is just a state of respiratory alkalosis. And again, it's because of the volume, it's because of the big old baby in the middle of her body. And the fact that she has to start getting rid of not only her CO2, but also the fetus's CO2.
Did you say respiratory or metabolic alkalosis?
Respiratory alkalosis, did I say metabolic alkalosis? I did not mean it. I meant respiratory alkalosis. Sorry. No, it's because of her increased metabolic rate that she needs more O2. One of the things that happens to make this easier, this squishing sensation easier, is estrogen converts into something called relaxin, which goes to kind of the cartilage in the body and relaxes that cartilage. So the rib cage will be much more flexible and it will open up and relax. The pelvis will open up and relax a little bit. Everything. The most important thing about the kidneys, the renal system, is that as the pregnancy grows, mom is going to have more and more pressure on her bladder, and she'll have a lot of frequency. Sometime in the second trimester, the uterus actually rises and it's not pushing on the bladder nearly as much. But then again, at the end, when lightening happens, again, mom is not able, there's no room for one thing, and she's having to go quite often. So what do we see with urinary stasis? Urinary stasis is the biggest cause of urinary tract infections, right? Urinary stasis. That is the biggest risk factor for UTIs, is urinary stasis. So important that as mom is hydrating, she's emptying regularly too. We don't want it to sit in there. So there's lots of skin stuff, and we'll start that in 10. Okay? All right. Okay, before we actually, I promised everybody they could see a speculum. Most of you ladies know what that is, right? So you warm it up. You can't usually put lubricant on it because the lubricant, if you're doing a pap smear, it might mess it up. Goes into the vagina like this. You turn it like this and open like this, so that you can see the cervix. Yeah, and it is just that comfy. And then they can lock it. I'm sure most of the girls are going, ugh. Then they can lock it into position. So, yeah, they autoclaved it before they. Yeah. They actually, in the clinic, hello, in the clinic, they actually do mostly use plastic. It's not so cold. They tend to be warmer, and they actually put them in a warming drawer. I don't know, we still use metal ones. So, okay, skin, lots of different things, lots of new words to learn. Okay. All right. So, melasma, cloasma, mask of pregnancy, it is actually this. Okay? Women get brown areas on their face during pregnancy. It's kind of, say it's like a butterfly shape, sort of. And it goes away after you deliver, but if you get sun on your face after that, you tend to tan more there. Okay? All right. Linea nigra. So line, nigra is black, black line. Is this line? We all have a line. It's linea alba, I think it is. That goes all the way up the middle. You can't see it because you can't see it until you're pregnant. And hormones turn this, and hormones were the cloasma reason too. Moms will have this black line. Again, it disappears after delivery is over with. Striae gravidarum are just these nasty stretch marks. Not everybody gets stretch marks like this. And hers are brown because she has more pigment in her skin. If you are lily white, they'll probably be kind of pink and red. They do fade. They never, ever go away. Once you've got a stretch mark, you always have a stretch mark. But they do fade to like a kind of a silvery white. They tend to be kind of shimmery in color, yay. But they will lighten up, definitely. Striae gravidarum, so they're lines of pregnancy. That's what that means. Yes? A bunch of bogus stuff. Yeah, definitely. There may be products that I don't even believe that there are products that really kind of fade them. They're going to fade naturally once there's pressure off the skin. Most women can look at their mothers, see what stretch marks they had, and it's usually hereditary. But you can have tiny, tiny women whose skin is stretched, and they don't have any, you know. So it's kind of Mother Nature's crapshoot again, you know. But oftentimes it's a hereditary thing. That's what I always tell them. They should, right? What? She does, huh? I'll have to look at that. But yeah, I've never heard that was a thing. Yes. No. Well, most of them have a little light on them, or you have a light behind you that shines into the cervix. Okay? Okay. All right. And then telangiectasia neae. Telangiectasia. They're just spider veins, people. So because of all the extra blood flow, there's more pressure on the veins, and the ones that are close to the skin kind of pop out a little bit. Here's a better look of linea nigra. Really dark there. Okay? All right. So we talked about relaxin, where the pelvic joints kind of relax, right? Relaxin and progesterone help with that. And moms will tend to have some muscle cramps when this is going on as the baby is sort of stretching things. And remember, the uterus has all those ligaments that are holding it up, kind of crossing this way, round ligaments, broad ligaments. they stretch too, and so that will cause a lot of crampy feelings also, okay? So that can be very uncomfortable, actually. All right. And then center of gravity, obviously, if you have all this weight in front of you and kind of weight all over, your center of gravity changes for sure. And so pregnant women tend to get kind of clumsy seeming until they get used to their different center of gravity, for sure. And then I think I have a picture. The rectus abdominis, nice tight little rectus abdominis muscle. Oftentimes during pregnancy, women's rectus abdominis will actually split. Not everybody's, but some women, their rectus abdominis splits open. You can fix it, but they would want you to wait until you are done having babies. But that's something that happens, kind of widens out. If your six-pack is just going to be like farther apart. There's just a space there. Yeah, dang it. It's it happens pretty slowly. It doesn't just go, pop out. Yeah, no, it's not even something women will say they notice. Yeah. The neurologic system, again, we have all this extra fluid volume, right? So there tends to be more pressure on nerves. Carpal tunnel syndrome, very, very common during pregnancy because there's more pressure on that area. And this is you're just looking kind of at the, A is mom's center of gravity when she's a nullipara. And then C, everything kind of changes. So it's very important for moms to have good posture with shoulders back, head up. If they're slumping like this, very hard on their spinal column. If you can see there, that curve is not a good thing. So, and then, have you guys seen pregnant women who kind of walk like ducks? That's kind of that center of gravity thing also. So good posture important. Here's, again, our rectus abdominis. Gastrointestinal system, what would you think would happen when there's no room? By the time you're at 40 weeks, there's zero room for your intestines are squished, right? So you have constipation, incredibly common. Because of that and because of the extra weight, very common for women to have hemorrhoids when they're pregnant. They may have internal hemorrhoids, but by the time they push the baby out, they're external hemorrhoids for sure. Not every woman gets hemorrhoids, but most do. Also, if there's no room for your stomach, you have pressure pushing up on your stomach, what do you think is going to happen? Reflux, heartburn, right? My best friend popped Tums constantly. She was always chewing on a Tums. All right, so all that happens because of increased pressure. Okay, this is a little, circle this one. When we, appendicitis, when you're diagnosing appendicitis, where is the pain usually? Lower right quadrant, right? Well, because of that baby taking up so much space, it can be all the way up here in a pregnant woman. McBurney's point is the point that we look at where the appendix is. And so McBurney's point will shift from down here to up here around the rib cage. I'd circle that one. It's just a fun fact. I did actually get asked that in my certification exam. So, okay. It moves up. Okay. Endocrine, obviously, it's a hormone storm. It's cray-cray. Table 13-6, page 299. 13-6, page 299. Hormones and effects on pregnancy. It's just, I just glance at it. There's no memorization that you need to do. We're talking about, you know, estrogen, progesterone, prostaglandins. Some of those kind of things are the most important things that we need to remember about pregnancy. We're not going to talk a lot about the other stuff. So, I don't know, you start talking about hormones and I'm just like, okay. So this is what the uterus looks like and where it is. And you can see the side view. Look at how much room there is on the at 4 months, how much room there is. You can really see the intestines. And then by 9 months, there's no room, right? There's absolutely no room. And the side view and the front view. So you can see how everything gets squished and pushed up and down. Okay, question. A number of changes in the integumentary system occurred during pregnancy. What change persists after birth? What doesn't go away? Epulis, cloasma, telangiectasia, striae gravidarum. D. Absolutely. They never go away. Red to brown to silver. Okay. Okay. Alrighty then. We talked about this yesterday. These are some of the terms. Oh, first I want to give you this. These actually, this is actually a coloring page with all of the stuff, a lot of the stuff that we talked about in, so the physical changes in pregnancy. If that helps you study, fabulous. If it doesn't, whatever. Throw it away. I don't care. Don't take it. You don't have to color it and hand it in. So, okay. So, prenatal period. This is just a review of terms. Prenatal period is that change. The time from when you get pregnant till you deliver the baby. So there's physical and emotional changes going on. Duration of pregnancy is the gestation. The gestation. Gestation of an elephant is like 2 years. Gestation of a human is 9 months. So 9 calendar months, 10 lunar months, if you prefer the lunar calendar. 40 weeks, 280 days. And there you can see our different trimesters. Trimesters have 3 months in them apiece, right? And then we have presumptive, probable, and positive changes. We're going to talk more about this. Presumptive, what I would do here, okay, because there will be questions related to these, what I would do here is circle presumptive, and then above it, beside it, put mom. And then circle probable, and beside it, put HCP, or doctor, or healthcare provider, midwife, whatever you want to put there, okay? And then circle positive and put fetus. So that will be an easy way as you're studying, just looking at that. So presumptive, those changes that are felt by the woman. So these are all signs of pregnancy. Some of these signs of pregnancy happen at the end of the pregnancy too. But anything that's felt by the mom that she feels pregnant, that's a presumptive. Probable, anything the examiner can actually see or feel. And then positive, if we know, we can tell the baby's in there. So listening to heart tones, looking on an ultrasound, palpating. Okay, so these are mom's presumptive indicators. And for the next 3 slides, for more detail, 13-2, table 13-2, page 286. Okay, it has this listed, so if you like to learn a different way. Okay, so not having a period, that's a sign that mom is going to feel, right? Fatigue, all this kind of stuff. When do we feel quickening? 16 to 20 weeks. What's quickening? First time you feel the baby move, right? Okay, probable indicators again. Healthcare provider indicators. The healthcare provider can see or feel the uterine enlargement. They can feel Hagar's sign. What's Hagar's sign? The softening of the lower uterine segment. They can see Chadwick's sign. What's Chadwick's sign? That the cervix turns violet blue. All right. What about Goodell's sign? Do you remember Goodell's sign? It gets puffier. The cervix is puffier, kind of a velvety consistency. Okay, so those are things that the physician is going to look at. Also, they will look at that positive pregnancy test. That's something that they can see or feel. Okay, and then the positive indicators, we know for sure there's a baby in there because we can hear the baby in there, all right? You can hear distinctly when can you usually hear the baby? Technically, it could be anywhere from 9 when, you know, that you have a 4-chamber heart that's beating. I mean, 4 weeks we have the tubular heart that beats, right? Usually it's around 12 weeks, so. So sometimes if you're in seeing the doctor for the first time and it's around 11 weeks, they'll try to listen, okay? All right. And then fetal movement felt by somebody else other than mom. So if I, you know, have my hands on mom's belly and I can feel the baby kicking underneath it, that's considered a positive sign. And then an ultrasound, because we can actually see the baby. Okay. Okay. When we do ultrasounds on pregnant women, early on they will have a vaginal ultrasound because that uterus is low in the pelvis. Later on, they will usually have an abdominal ultrasound. So just okay, estimating birth date, we did this yesterday. Just some of the terms that we see. Estimated, when I started, it was estimated date of confinement, EDC or due date. Now they say estimated date of delivery. We still see that a lot. And then you guys figured out Nagel's rule yesterday. Okay, the most, to really figure out baby's age, when do you think the most accurate ultrasound is? Early in the pregnancy or late in the pregnancy? Connor, commit. Okay, why do you think it would be early? Because it's early. So why do we think it would be early? We want to know close mom's due date. Maybe mom doesn't know when her last menstrual period was. Maybe baby's measuring small or large. An early ultrasound, especially in that very first trimester, what's happening? Development. And we know when things are being developed. So if I go in and I can see a little bean with a tubular heart, I know the baby's around 4 weeks old. If I go in and I have a 4-chamber heart and it's beating, it's at least over 6 weeks, right? Because I know when the gastrointestinal system is being formed. All of those things that were on that table yesterday, we know exactly when the weeks that those are formed. And so from that early ultrasound, that is the most, definitely the most accurate way of determining gestational age. So some moms don't have an early ultrasound. Maybe they'll just have like one at 22 weeks. Just depends. Okay. So a gross estimate of dates is kind of this, like, I'm going to look at physical things and give you kind of an idea, all right? So measurement, we always measure mom's uterus when she comes in to see us. So we measure from the top of the symphysis pubis all the way up to the fundus. The fundus is what? Top of the uterus, right? So we go all the way to the top, and we measure that. So if mom measures from the symphysis pubis to the umbilicus, how many weeks is it? 20, right? At 20 weeks, baby's at the umbilicus, the uterus is. So after that 20-week period, 20 centimeters, it usually rises about 1 centimeter a week until 36 weeks, and then it just depends how big the baby is. Okay? So, above the symphysis pubis at 12 to 14 weeks, at the umbilicus at 20 weeks, if you're worried about the whole blanks thing, which I know you are. Okay. What was I feel like I...
Did you say 12 to 14?
Yeah. Yeah. So when you do Nagel's rule, again, like I said yesterday, there's lots of assumptions there. It's got like 5% accuracy for due date. You know, if you use Nagel's rule to figure out somebody's due date, it's 5% chance that they're actually going to deliver on that day. It's pretty rare. So the leeway is 7 days before to 7 days after, so like half a month that you have. Okay. All right, so now we're going to talk more about psychological adaptation to pregnancy. How many pregnancies are unintended? 50%. So there are some women who find out they're pregnant and they're not happy about it. That's not unusual at all, right? So they may be upset. Also, with the changes in hormones, mom is going to be very, very susceptible to mood swings, right? So you need to know that ambivalence is normal. Ambivalence is normal. When a woman first finds out she's pregnant, ambivalence is normal. What's ambivalence? What's ambivalence? You're not sure how you feel. You may not be wildly happy about it. And what goes into that? It's scary. You know your life is going to change. You may not have planned this, so you're upset about it, but it's okay. It's normal for this some ambivalence to persist through the 3rd trimester, okay? So you can have times where you're not that excited about being pregnant, about actually having a baby. You're scared for the delivery, okay? So accepting the pregnancy can it's a continuum. It can kind of go back and forth. Moms tend to feel guilty, okay, if they're not so thrilled. And so they just need to know that that's okay, that's normal. They need to reassure. When we get up to delivery time, if she's still saying, yeah, I don't want to be pregnant, then we definitely have a problem. So in that last trimester, we want her to have this resolved, really. Identifying with mom's role. Usually women are conditioned for the mother role as children when we have dolls. Kira didn't ever have any siblings that were around, but when we gave her a doll, she knew that, and she was like 2, she knew she would hold it, and she knew where to put the bottle, etc. So there's some kind of inner nurturing, but also societal conditioning. Are you okay? Oh, dang. I'd be a mess if I had to be on crutches. I'm a total, yeah, it would be a wheelchair for me. Okay. All right, and then babysitting, etc. Okay, also the identification with the mother role, again, you need to resolve that by the time you have baby. Okay, and then reordering personal relationships. It tends to be kind of an intense time. Women have an intense relationship, more intense with their own mother during this time, with their partner during pregnancy. Things are changing a lot. Sex is an issue. Everything is different, and it's really never going to be quite the same again. So that takes a lot of acceptance. And so part of the deal is we want mom and the fetus to attach by the time, dang it, she delivers. It's okay. Yeah. Okay. So these are the phases of emotional attachment. By phase 3, she really wants that pregnancy to be over. So how do we in Western society normally prepare for child abuse? Ah! God, what the heck was that? Dang. Childbirth. Whatever. Okay, what do we do to prepare for childbirth? Buy clothes, get pregnancy, maternity clothes. What?
Nest.
You nest. So what's nesting, Janaea?
You clean like crazy. You try to prepare for every situation that you don't even know could exist.
Yeah, you're reorganizing. You're kind of feathering your nest. It's exactly what it is. Classes, a lot of women go to classes in the first pregnancy. They'll ask a lot of questions. They get a lot of unasked for advice. People say things to pregnant women that they would never consider saying to anybody else, okay? Oh my God, my cousin died during labor, stuff like that. So there's a lot of anxiety that gets attached to this. I love this. I know, right? But all the horror stories, right? Janaea, did that happen to you? Who else has a baby? Did you hear? Yeah, and people feel like they can touch you. Yeah. Did you get touched? Yeah, I asked. But I feel like I should be able to whenever I want. Yes? Yeah. Yeah, okay. See what I mean? It's shocking, yes.
I was with Janaea when I was pregnant, and I had this patient's family member, I was in the room and I was doing stuff, and she came up to me and she goes, oh my gosh, you're so cute, and I'm like, never met this lady.
Do not touch me, right? Yeah, and you're trying to slap her hands away and not get fired at the same time, right? This is one of my favorite pictures in the whole book because this chick has twins, okay, right? And her husband is like, yeah, this is so cool, right? And she's like, I just want this to be over. Yeah, she does not look very happy at all right? And he's so thrilled. I did this. You know, it's a sign of virility, right? Okay, so all right. So dads have to go through adaptation too. Dads have to go through adaptation too. So they have to also accept the pregnancy. And again, there's a ton of changes that go on. Accepting the pregnancy, we have Couvade syndrome, which sounds like a serious disease. Does anybody know what Couvade syndrome is? It's a thing. Yeah. Yep, start to get the symptoms like the ankles are swelling, you got some nausea, there's a little vomiting, their clothes are getting tight. Yeah, it's an actual psychological thing. No, called Couvade syndrome. It happens as that father is accepting the pregnancy. So. I think a little of it is common, yeah. But it can get really crazy. So as he is, men are also conditioned to be fathers, whether we know it or not. Usually they're kind of looking at their own father and what they did. And then these are the phases for the expectant father. So the announcement phase is basically saying, yeah, this is my baby. Which, trust me, this doesn't always happen until 2 weeks after the baby is born. So one of the kicks of this is that, and one of the assessments that we really have to do, intimate partner violence assessment, because if this was unplanned or unwanted, if there is any kind of abuse going on, whether it be verbal or physical, it will escalate during pregnancy. So, and then moratorium is adjusting to the fact that, yes, he's going to be a father, and then thinking about being actively involved with Mama-san. So, paternal adaptation, also identifying with the father role. They think about their own memories of their own fathering. So, this can get a little tricky when someone grows up in a home without a father, right? Which is really common in the United States. Sex can be very stressful for the male when female is pregnant because he's worried about hurting her or the baby. And mom tends to be more vulnerable. She's uncomfortable. It's like the last thing she wants to do when she gets to a certain point. So again, in any sexual relationship, there's negotiation, and this is a time in mom's life and dad's life that they need to be negotiating, talking about what's okay and what's not okay in sex. And then dad establishes a relationship with the fetus. That does also begin during pregnancy. A lot of the time, once they can hear the baby's heart rate, see the baby on ultrasound, but especially once the baby is kicking and they can feel the baby move. And then they really worry about getting mom to the hospital. My dad, my mom, I'll tell you my birth story someday, but my mom they gave her something to start her labor and everything, and I was a month overdue. And my mom, so they get to bed, because they went out partying, because that's what they did back then. My mom is like, 3 in the morning. They've been in bed for an hour. Hey, it's time. And he wakes up and he looks at her. Time for what? It's like, no, we got to go. And it was a 45-minute labor. So they really needed to go. Okay. Adaptation to parenthood for the non-pregnant partner, especially in same-sex, partnerships, relationships. that other partner can really feel left out, especially female-female relationships. So really important for all partners to have them in the process, include them in the process. And then for siblings, if this is a second, third, fourth, fifth, sixth pregnancy, depending upon the age and the developmental stage, a lot of times babies will regress. For a lot of children, this is the first major crisis in their life. Okay? My brother wouldn't look at my little sister for 6 months. Like, he physically, all the pictures we have of them, he's physically turned away from her. Yeah. Okay, grandparent adaptation. For grandparents, they might feel old. So that would, yeah, trust me, that's not fun to feel old. They tend to carry that family history, so they can be an important part. They can also be incredibly intrusive and cause stress for moms. So it's important to kind of, it's the father's job to protect the mother from the children and from his and her parents. So there's tips for sibling adaptation, box 14-2, page 307. So just take a glance at that. What happens when those children are in crisis? What usually happens if we have a 2-year-old, potty-trained 2-year-old or 3-year-old, that baby wants to go back, right? Go back in time when they were a baby, or they want to breastfeed, or they want to start sucking on a pacifier, okay? Incredibly normal. Okay, prenatal visit. This is our prenatal interview. We're looking at all of these things. So our goal in prenatal care is to foster a safe pregnancy, a safe delivery. We get a good, healthy baby and a healthy mama. We also want them to have a positive birth experience. So we want them to be satisfied with their pregnancy and satisfied with the birth. 75% of women seek care in the first trimester, so within that 12 weeks. 25% of women not seeking care is really a big amount, a large amount, and as we go into problems during pregnancy, you will see what happens if we don't catch some of those things earlier. So we want to know what mom's immunizations are. We'll do titers to see, and we're also going to look at drug use. That's a big one now. And then you guys can see that. Review of systems. You guys know about this. Supine hypotension. What is that? Supine hypotension. I talked about it, but I didn't say the name. That's when, if mom's lying on her back, the uterus is sitting on the inferior vena cava and stopping circulation, and we have hypotension. All right? So what do we do to take the compression off the inferior vena cava? We always have mom tilted to one side or another. Tilting mom over will just take that weight off the inferior vena cava. Mom will feel faint. When they have supine hypotension, they'll feel faint. And so I want you to look at emergency box 31-3. I have no idea. Obviously, it's in chapter 31. I don't know the page number. So they'll do one vaginal exam early on. They'll do a speculum exam, check out the cervix, looking for Goodell sign and Chadwick sign, and they'll check Hager sign. All those things are really on the early things. And then they keep their fingers out of there until later on, all right? So, let's see. There is a list of a table of lab tests on page 312. Oh, you know what? The emergency box is on page 313. Duh. And then some of the diagnostic things that we look at, for STIs, obviously, we check concurrently for chlamydia and gonorrhea for sure. We have to have permission to check mom for HIV, and we check everybody's or Hep B status. Most women get checked for HIV now, though. And then also they're going to check urine every time mom comes in for her spilling protein and glucose. So when they come in for follow-up after the initial visit, they get measurements, weight check, they check the urine, they check fundal height, they ask about quickening, they compare with the expected due date to see if mom's measuring okay. And an interesting fun fact, by the second trimester, the uterus, because of all the fetal growth, is considered an abdominal organ, not a pelvic organ anymore. So. Okay, so we want to also, we'll do a fetal assessment. And I have some things that we use for fetal assessment. This would be one of them. Okay? This is actually a fetoscope I've actually used, this very fetoscope. This is without any electronic help, how we would listen directly to the baby's heartbeat, okay? We would listen via the fetoscope. Most of the time, they just use a Doppler now. When you put a woman on an external fetal monitor, sometimes the monitor will double mom's heart rate, and so you don't get an accurate idea of what's going on with the baby. So you always should check the baby's heart rate physically rather than electronically, okay? They don't use this anymore, obviously, because they gave it to me, right? Okay, so this was like huge technology because before that, we use this. This is a Panard. I'd hold this to mom's belly and listen, and it's almost impossible to hear anything through this. I've tried. But now we use a Doppler. We use a little conductive gel, and actually most Dopplers now have speakers in them, so you don't have to use this. And yep, and then we would just listen to the baby's heart rate via this. So that's how they do it in the clinic. So yeah, those are all the different ways. And you can see the fetoscope. That fetoscope is not as fancy as mine, for sure. I like mine better. And this is what it sounds like. It's kind of muffled, sort of a souffle. This is 16-weeker. That's what it sounds like. Okay. All right. So, there's a box on page 319 also that talks about teaching mom about self-management. But in, nutrition is really important, but mom will have increased sweat and more oil glands that are bigger, so she can get a little smelly, so she may end up bathing more. We talk about urinary stasis. Actually, if you don't empty your bladder often enough, that big bladder can actually cause preterm labor. Okay, so we don't want that. The Kegel exercises, you guys know, will strengthen the pelvic floor. Dental health is really critical. I just saw a Call the Midwife episode where they had to take out all this lady's teeth. They were gross. But very, very important. We know big source of systemic infections are infections in your mouth. Okay? So that is a really key thing. And then for breastfeeding, if mom has inverted nipples, you can do things to try to evert them during pregnancy. And then on page 321, it talks about physical activity. Pregnancy is never a time to escalate what you've already done. If you're sedentary, you should walk. If you're a runner, you can run until your uterus slows you down. I took care of a physician friend of mine who's a marathon runner, and she ran a marathon 2 weeks after she had her baby. I wouldn't recommend it. It slows healing, but she's, crazy runner. Okay. All right. That must be time to leave, right? Again, because of that change in the whole whatchamajiggy, center of gravity, it really is time to leave, isn't it? Body mechanics, posture, really important. And otherwise, moms can pretty much do anything they need to do. Low seatbelt against lap. They don't like moms flying after 36 weeks. My cousin is a flight nurse for NICU in Sioux Falls, and she would fly until her flight suit wouldn't fit, which was probably later than 36 weeks, but okay. And then we don't ever give live or attenuated vaccines. We do give flu shots always. We want mom to have had a recent Tdap. The Tdap is mostly because we cannot vaccinate babies for whooping cough, and whooping cough is deadly for babies. And so we want everybody who will be around that baby to be vaccinated with a Tdap. Okay. Some of the high points of this. What potential complications would we worry about? This is important. Vaginal bleeding. Painful urination. Excessive vomiting. So we teach patients, we tell them, we give them things in writing. And we tell them, if you're not sure, call the doctor. Preterm labor, one of the first signs of preterm labor can be a backache or cramping. So they need to know that. Usually there's no restrictions to sex unless mom has had some abnormal bleeding or preterm labor, and then they have to. And then there's positions that are more comfortable for pregnant women on page 330. We also would screen for depression, anxiety, that kind of stuff. There's mama with the belt low. I'm just going to integrity the rest of this